Actually, I'm seeing we have 42 folks, so we'll go ahead and get started. Hey everybody, this is Cicely Burrows-McQueen at SAMHSA. It's really great to have so many of you joining us from across the United States this afternoon as we continue our learning community series focusing on engaging service members, veterans at risk, looking at best practices, tools, and resources for SMVF, screening, and suicide risk assessment in particular. Today we have some experts from VA that are going to be sharing their knowledge base with us, and we hope you'll also participate through our question and answer and chat functions. As many of you have been on a lot of our virtual learning activities over the past several months, if you have any issues at all, we have the technical assistance staff standing by to help troubleshoot. And again, as Erin said at the top of this call, we do plan to record this session since so many folks are doing double duty and triple duty on coverage within their own communities at this time. We want folks to be able to still benefit from this great resource. And so it'll be recorded and shared with anyone who's registered, and you can feel free to share it down the road as well with other colleagues who may benefit from this knowledge. That being said, on behalf of everybody at SAMHSA and our partners at VA, who you'll hear from in just a second, we wanted to thank you for taking time to join us today. Let's go to the next slide, please. So you can see my photo on the left. You'll hear from Edgar in just a moment, and Donna's here in the background to help with all of the Q&A, as well as Angela Wright from our Service Member Veterans and Their Families Technical Assistance Center. I should add that today the disclaimer that comes with any of our materials is that they don't necessarily reflect the views and opinions of the United States Department of Health and Human Services, or VA, but we fully vetted these amazing speakers, and I think you'll learn a lot from this material. Just had to get that disclaimer out of the way. So let me take a moment and again give a great intro to an amazing partner on behalf of all of our work that we do with the Governor's and Mayor's Challenge. It is really with the encouragement and expertise of the VA staff that help us to bring this information to you and help drive this work. And so we're honored to have Dr. Edgar Villarreal join us from the Office of Mental Health and Suicide Prevention to do the VA welcome and introduce their speaker for the day. Edgar?
Great. Thank you, Cicely, for the warm welcome, and thank you to all of our SAMHSA partners and our SMVF TA Center for coordinating this ongoing series of technical assistance calls. It's my pleasure to be here today with you on behalf of our National Program Office and to have the opportunity to present to you on this important topic regarding tools and resources for screening and suicide risk assessment. We have a really great speaker in line for today, Dr. Bridget Matarazzo. She is the Director of Clinical Services for our VA's Rocky Mountain MIRIC for suicide prevention. So we owe a great deal of gratitude to her, her team, and the MIRIC for the great work that they continue to do in helping advance suicide prevention best practices, both within the VA and outside of the VA. So without further ado, I'll hand it over to Bridget. And thank you again, Bridget, for allowing us to have you and for sharing your time and your knowledge with the group.
Thanks, Edgar, for that. It's Cicely again. I just wanted to quickly let folks know who's on the line as we hand off to Bridget next. So if we can go through that next slide, I wanted to just welcome, as we mentioned, we had folks from over 28 states and the District of Columbia register for today. So we're very well represented in those folks that are learning and listening to the material. So again, thank you guys for joining us today, and we really look forward to your questions. All right, next slide. And Bridget, the floor is yours. One more slide. I promise that was the last one.
All right. Well, thank you all so much. Thank you, Edgar, for such a lovely introduction. Edgar has been a longtime colleague of mine, and I was very grateful for the opportunity when he asked me to present on this call to you all today. I have heard about the work that you all are doing for a long time and think it's critical to what we're doing in VA, and I'll be talking some about that and then really kind of honing in on what we are doing in terms of identifying suicide risk in VA. And, you know, my hope today is that we can just share these ideas about what we're doing, so you all could consider how you may or may not want to implement any of these practices and policies in your organizations. And I'll also, step aside a little bit from what we're doing to talk about how they fit into things like clinical practice guidelines and Joint Commission requirements, so that you can be considering them in that context, because of course we have lots of different bodies and guidance that we want to be adhering to. So I'll try to offer some thoughts and suggestions along those lines as well, and then wrap up with some resources that sort of go a bit beyond just risk identification and screening, but are free and available to you all as partners in veteran suicide prevention. So certainly want to make you aware of those. Okay, and team, would you like me to just advance my own slides? I'm happy to do so.
Sure, if you feel comfortable with it.
Okay, great. That might be easier. Okay. As Edgar mentioned, I work in an entity in the VA called a MIREC, or Mental Illness Research Education and Clinical Center. For those of you who are unfamiliar with those, there's 10 of them across the nation. They're congressionally mandated translational research centers. So we have a research core, education core, and clinical core, really with the idea that we, within our own center, can be doing high-quality research, use our education team to really help disseminate that research, and then our clinical team helps support implementation of that into practice. And we all work very closely together, and sort of members from each of those cores have worked together to support a lot of what I'll be talking about today. It's been a really nice collaboration within our center, but also with the larger Office of Mental Health and Suicide Prevention in VA. So same disclosure that was gone over earlier, this presentation is based on work supported by VA, but does not necessarily represent the views of VA or the United States government. So I'm going to start with a little bit of background about veteran suicide prevention. I'll do this pretty briefly. I know that you all are very engaged in this work, so certainly know a lot about sort of the statistics around veteran suicide prevention, but just to make sure we're all kind of on the same starting place, I will start there. So just a few facts about veteran suicide prevention. Much of these data come from the National VA Suicide Data Report that is online. If you just Google that, it's easy to find. It is updated regularly with new data. But currently what we're seeing is that about 18% of all deaths by suicide among U.S. adults were veterans. There's more than 6,000 veteran suicides each year in a pretty long time frame. Importantly, the suicide rate was 1.5 times greater for veterans than non-veteran adults. I always keep that sort of 1.5 times greater in my mind and in the forefront of my mind in terms of why we are really valuing our suicide prevention efforts. We know that about 17 veterans die by suicide every day. About a quarter of these folks have a history of previous attempts, and they are absolutely more likely than the general population to use firearms as a means for suicide. And so you'll certainly hear from VA and our partners lots of focus on lethal means safety, and specifically focusing on firearm safety for that reason. It is by far the most common cause of death for our veterans who die by suicide. So this slide, I think, is really important in terms of our partnership with folks outside of VA. We know, as many of you do, that 50% of veterans do not use VA health benefits. And more specifically, 11 out of the 17 who die every day are not enrolled in VA care. So we absolutely cannot do this alone. We need to be partnering with non-VA organizations if we are wanting to end veteran suicide, which is the top clinical priority of VA. It is not just to end suicide among veterans who seek VHA care. It is to end veteran suicide across the board. And so these types of partnerships and all of the hard work that you all are doing is integral to that. Okay, so, you know, the VA sort of has this motto of suicide prevention is everyone's business, and we think about that in a lot of different ways. We think about that across our healthcare system so that everybody who works in our healthcare system has a role to play, but then of course that extends into our community. So we think about our role and the community's role in developing innovative prevention strategies, and that can, sometimes come from our frontline providers, sometimes it's coming from our research partners, and getting that out to the field. We want to be changing the conversation around suicide to decrease stigma, building community engagement, absolutely, and reaching veterans and their families and truly partnering with those most directly effective. And so those types of approaches are really best described in a public health approach to suicide. And you'll see that really clearly represented in the National Strategy for Preventing Veteran Suicide. This is also available online to you all. Again, I'm sure many of you are familiar with it. But the approach I'll be talking about today, once I start kind of narrowing my focus on screening and evaluation, is consistent with this national strategy, partnering with you all like I'm having the opportunity to do today on this call. All of that is consistent with this national strategy. So in that national strategy and thinking about kind of a public health approach and a population-based approach, some things we think about are universal, selected, and indicated approaches to suicide prevention. So universal approaches, it's strategies that are designed to reach the whole veteran population. And again, you'll see this reflected in the strategy I'll be talking about in a bit. In terms of selective, this is sort of the next level. These are prevention strategies that are designed to reach subgroups of the veteran population that may be at increased risk. And then when we're talking about indicated, this is folks in our veteran population that are identified as being at high risk. And so you can develop your prevention strategies talking about identification or talking about treatment and management in these different areas. And you may hear folks, talk about upstream approaches that were really targeting more universal and selective populations to hopefully help them or prevent them from getting into this indicated bucket, but then also more indicated strategies that are really tailored to the high-risk groups. And so our screening and identification strategy maps onto this. So the other piece I wanted to cover in terms of what our approach is consistent with is the updated VA/DoD clinical practice guidelines for the assessment and management of patients at risk for suicide. That is a mouthful, so I will just say the CPG moving forward. This was updated last year. It came out almost exactly a year ago, last summer. The updated version of the CPG, myself and a few colleagues from the MIREC were part of the work group involved in the update to the CPG. To update the CPG, it's important to know that it is a very rigorous evidence-based process. So it involves stakeholders from both the VA side of the house and Department of Defense. The CPG was also reviewed by many of our community partners prior to publication. It involved a systematic review of the evidence, and in that systematic review, we come up with individual studies that can speak to things like the best ways to identify suicide risk, and then we also evaluate the entire body of evidence. And we use all of that to come up with evidence-based recommendations. And so I'll be sharing the ones that are related to screening and identification in a moment. Importantly, the CPG, part of sort of the introduction to it, it talks about the population of interest for the CPG. And importantly, it's for patients at risk for suicide who are eligible for care in VA and DoD healthcare systems and those in the community. So if you're wondering, okay, VA, DoD came up with this, does it apply to the work we do? Absolutely. It was designed and written with the intent of our community partners utilizing this as well. Certainly, if evidence was directly from the VA system of care or Department of Defense, we included it, but we also included really strong evidence from just the larger community. And so this certainly applies across settings and is applicable to your organizations as well. So in the updated CPG, there's a total of 22 evidence-based recommendations. There's 5 in the area of screening and evaluation. And they're on this slide. I have a screenshot of them. You'll see that there's 2 related to screening, 3 related to evaluation. I'm not going to read through these, but just in brief, the recommendation was that with respect to universal screening, we suggested the use of a validated screening tool to identify individuals at risk for suicide-related behavior. So certainly recommending that a validated tool be used for this process, and I'll be talking about some of those later on. And with regard to selecting the universal screening tool, item number 9 from the PHQ-9 had very strong evidence based on our evidence review, so that was recommended to be used to identify suicide risk. Then when you move into the realm of evaluation, which for some folks you might be wondering, what exactly is the difference between screening and evaluation? I'll get there in just a moment too. But for evaluation, there's some risk factors that have sort of the strongest evidence behind them. So you really want to ensure that they're involved in any comprehensive evaluation of suicide risk. And they're listed on the slide here and sort of detailed in the CPG. You also want to make sure that you're using sort of multimodal method for evaluating risk. So not relying on just one instrument or method is the biggest thing. So for example, if you were evaluating risk, you wouldn't want to only rely on one validated instrument for that. Every instrument has pros and cons, and you're going to want to supplement with additional information. And we'll get to sort of our approach for that in a bit. And then while it is an expected standard of care, there is insufficient evidence to recommend for or against the use of risk stratification. So I can unpack that a bit. There's a lot in that sentence. So in terms of CPG language, when we're talking about insufficient evidence, that doesn't mean no evidence, and that does not mean contradictory evidence necessarily. Insufficient just means that it didn't hit the very high bar we had for including something as a recommendation. We had a high bar for the amount and the rigor of evidence that needs to be in existence. So it doesn't mean that there's evidence against it. It just means there is insufficient evidence to make a recommendation. That being said, everybody on the work group agreed that it is certainly an expected level of care, expected standard of care that we are stratifying risk. And as we'll go over in a bit, that's also something that's required by Joint Commission. So certainly wanted it reflected in our approach that we would be stratifying risk. And again, I'll get to the details of how we're doing that. Okay, so one other piece that is involved in the CPG that I wanted to point out are these algorithms. In the algorithms, this kind of walks you through what a flow might look like from screening to evaluation in different scenarios. Really helpful, I think, for frontline providers to check that out and see how that flow might happen. We have resources mapped onto it throughout the CPG and also talk about the recommendations that are mapped on. What I have on this slide is just one little screenshot of part of one of the 3 algorithms. And what it talks about is the 3 different ways that we might be identifying risk in a healthcare system. And so I will be now diving into these 3 different components. I will cover briefly some ideas for what we could be doing to identify warning signs, what we're doing in VA using predictive analytics, and then I'll spend the bulk of the time today talking about screening and sort of our processes therein. But these are sort of the 3 ways to think about how we are going to identify risk in a healthcare system. So we'll start digging into those. So the first is warning signs. So we try to provide or train our providers across areas in VA. So whether we're talking about primary care, the emergency department, outpatient mental health, try to train them in identifying clinical warning signs because our screening requirements only go so far, right? If they're not required to screen at every single session, we need to make sure we have other ways of picking up on risk, and that might be clinical warning signs. So warning signs signal an increase in the likelihood that someone may engage in suicidal self-directed violence in the immediate near future. So that's sort of the technical definition of clinical warning signs. This is like a red flag that something could be going on and we should check in with this person. They can be direct or indirect, and I'll talk about those in a moment, but in either case, they sort of, again, are sort of like an alert that we need to directly be asking about any suicidal thoughts. Okay, so if we think about direct warning signs, they can fall into these different buckets of direct suicidal communication. Somebody might be talking about suicide. You might have a family member connect with you all and say, hey, my loved one has been posting things on social media about suicide that are concerning to us. What should we do? That could be considered a direct warning sign. Then seeking access or recent use of lethal means. So somebody, we discover that they've been stockpiling medications, for example. That is an example of a direct warning sign. Preparations for suicide, evidence or expression of intent, making steps towards a plan, making arrangements for their eventual death, things like that. These are all really direct warning signs. These are like your really huge red flags that you want to immediately be checking in with somebody. Then there's also a whole host of indirect warning signs. What I will say about warning signs that's critically important is that these are person-specific. So somebody, for example, might have trouble sleeping, and it has nothing to do with suicidal ideation. They have a sleep disorder, but they're fine in terms of suicide risk. But for somebody else, it could be indicative. It's never going to be a bad idea to check in with somebody and see how they're doing if you see these things going on. They might not be indicative of suicide risk, but perhaps the person just needs some support and help. So certainly not a reason to not check in because we're not sure. We want to keep these things in our mind that they could signify increased risk and certainly warrant checking in with somebody. There's a whole host of them on here. Again, I'm not going to go through each one, but we want to think about how these things are relative to a person's baseline. So if I'm working with a veteran on an ongoing basis and I know that they typically have, 2 beers before they go to bed at night, then all of a sudden they start saying, yeah, I've been having about 5 or 6 every night. I'm going to think, okay, that's an increase from their baseline. I got to check in with them and see what's going on. So again, really getting to know the person in front of you and knowing what is a change in their behavior is important. So that kind of briefly covers the warning sign arena and way of identifying folks that might be at risk that are presenting to care. The other way that we're doing this in VA is through predictive modeling, a program that's called ReachVet. I could talk about that for a whole nother hour, but I won't do that today. But we are using a predictive model that was developed by a team in VA and in partnership with NIMH that we use to identify veterans who are being seen in VHA who are at the highest statistical risk for suicide and other adverse outcomes in our healthcare system. So it uses data from the medical record. Once we have folks identified, their providers are required to reevaluate their care, outreach them to see how they're doing, and make changes to their care in whatever way they deem important to in collaboration with the veteran. So this has been going on for a few years in VA. There really aren't any programs quite like it at the scale that we're doing in VA. Certainly if this is something that's of interest to you, feel free to reach out to me and I can give you more information on it. But just for purposes of today, I wanted to make sure you all know that this is another way that we can be identifying folks at risk in a healthcare system. All right. So now I will really dive into what we are doing in terms of our population-based screening and evaluation in VA. We call this strategy VA Suicide Risk Identification, or Risk ID for short. And so I'll transition into there. One way that I'm going to sort of be anchoring this discussion as we go through it is kind of highlighting the continuous flow of information between research and policy and practice. And this has been really integral into the development and implementation of our risk identification strategy, and I'll kind of carry that through in the discussion. A second, I seem to have lost my ability to advance. Oh, there it is. Okay. All right. So when you, I don't know about you, but oftentimes if I think about folks who are presenting to care that are at risk for suicide, previous to learning about all of this, I might have thought, well, yeah, those people are probably coming into our mental health clinics, and our mental health clinics are good at identifying this stuff and managing it. So we're good. We just need to make sure our mental health providers know how to identify and manage risk. Well, that's not necessarily true. So what we know from the literature instead is that many people who die by suicide were more likely to be seen in the emergency department or other medical settings like primary care shortly before their death by suicide. So they might not have been involved in mental health at all, and oftentimes they were more likely to be seen in medical settings than mental health closely to their time of death. So what does that tell us? That tells us that we absolutely need to be doing more across our healthcare systems, not just in the mental health space, to be identifying our folks that are potentially at risk. The Joint Commission came out with a Sentinel event alert in 2016 calling for suicide risk screening in medical settings. So they certainly were up and aware of this evidence and called for this change to be made. And that's part of what spurred what we are doing in VA. So starting in 2018, VHA mandated the risk ID strategy. So this is the first time that VHA had a standardized evidence-based strategy for suicide risk screening and evaluation enterprise-wide, so throughout our entire healthcare system. Before we did this, we didn't have a consistent policy in mental health across VHA. Folks were evaluating risk in different ways. Certainly in mental health, it was being asked about all the time, but might not have been in the same exact way. So we thought, okay, we have a few goals here. We want to standardize what we're doing so we can ensure a certain level of quality across our system of care. And also, we want to expand this out of mental health and really integrate this into medical settings for the reasons I already went over. So in May of 2018, we sent out an informational memo to the field, letting them know that this was coming, and then starting in fiscal year 2019, which is October 2018, we implemented this enterprise-wide. Okay, so as I mentioned earlier, this is a population-based approach to suicide risk screening and evaluation. What that means is that we are covering all of those domains I went over earlier. So if we translate that into specifically screening, if you think about universal screening, for example, in the emergency department, every single veteran who gets seen in any emergency department or urgent care center in VA gets screened for suicide risk. So if you show up for a broken arm, you are getting screened for suicide risk, every single person. And that is truly universal screening. Then we are also doing things that are more like selective screening. So for folks who could be at increased risk. So this is, for example, in our pain and sleep clinics, we know that pain and sleep are particularly important risk factors for suicide. So the idea is that if somebody is presenting for an intake into pain or sleep, they should also be screened for suicide risk. And this could be in addition to a yearly screening in primary care or in ED. Then we're also doing indicated screening. So this would be at folks that have known risk. So for example, on an inpatient psychiatric unit, we know that there's a tremendous level of risk associated with that. So all of those folks are getting screened at admission and discharge. So population-based means that we are really covering all these different subgroups of the population to ensure that we're screening across the board. So this is that slide I was saying before that I would cover about kind of the difference between screening and evaluation, because this will be important to keep in mind as we continue to dig into the weeds here. So when we're talking about screening, we're talking about a process to identify veterans who may be at increased risk. So this is, we screen for a condition to identify the potential of it existing, right? So this is when you go to the doctor and you might get screening questions about your health history, your family's health history, different symptoms you have, and they're using that information to decide if you need further evaluation for a condition. Well, this is the same thing. So screening kind of casts a wide net, identifies folks who might be at risk, and then we narrow that down with evaluation. So evaluation is when we're really digging in to gather much more specific information to evaluate a veteran's acute and chronic risk. I'll talk more about that in a minute, what I mean by that. And we use that information to develop an individualized risk mitigation strategy. So we first identify it through screening, then we make sure they're going to get a comprehensive evaluation so we can really understand why this person is at risk, what is driving that risk, so we can figure out exactly what to do to help mitigate risk. So that's sort of how screening and evaluation go hand in hand, and one flows into the other. So in the VA setting, I mentioned that we're doing this across the enterprise. So we are implementing this in primary care, emergency department, inpatient and outpatient mental health, in our inpatient rehab and medical surgical care. So if you come in for a surgery, you will also be screened for suicide risk. We are doing this in our residential treatment programs, our community living centers, which are most akin to like a nursing care setting, and in our sleep and pain outpatient specialty clinics. So truly across almost every setting of care in the VA. Okay. And so we're doing this through a 3-stage process in many settings. So we start with item number 9 of the PHQ-9. So in settings like primary care, there are annual screening requirements for depression and PTSD. So what we did is tacked on item number 9 to those screenings so that folks would be getting screened for suicide risk as well. And again, that's to cast a really wide net and identify those who may be at risk. If that's positive, then they move on to a secondary screen, so sort of like a higher level screen. For that, we're using the Columbia Suicide Severity Rating Scale screener version. There's a lot of different versions of the Columbia. We are not using the full measure. That is more of an assessment tool. We're using the screener, which is shorter. I'll show you those questions in a bit. And in that, we're kind of really digging into more questions about suicidal thoughts and behavior with the aim of improving the specificity of our screening. So casting that wide net, hoping to narrow it down in terms of specificity with that second level, and then only those folks who have a positive secondary screen move on to the full evaluation, which is called the VA Comprehensive Suicide Risk Evaluation, or CSRE. And that is done through clinical interview, which then gets documented via a note template that we have in our electronic health record. And it's designed to make sure that in that clinical interview, our providers are hitting all the critical elements for a comprehensive evaluation. They're informing their impressions about acute and chronic risk and the associated disposition or risk mitigation strategies. So the primary screen, if you're not familiar with what item number 9 from the PHQ-9 is, it is over the past 2 weeks, how often have you been bothered and by thoughts that you would be better off dead or hurting yourself in some way? There's some good evidence out there in terms of the predictive validity of this question in terms of predicting future suicidal behavior. That's why it made it into the CPG and why we chose to use it as our primary screen. The secondary screen, like I said, is the Columbia screener. If you go onto the Columbia Lighthouse page, which is the link I have on here, the version you will see has 6 items, and questions 5 and 6 have sort of 2 questions embedded in them. So for ease of administration in our medical record, we broke them out into separate questions, but we score it just the same as is done on the Columbia website and their trainings and what has been used in the literature. So we have a positive Columbia is a yes to items 3, 4, 5, or 6B. So at a minimum, our folks who are endorsing ideation that are saying that they may have been thinking about how they might kill themselves, so thinking about a method, those folks would screen positive. But on the other extreme, they may have actually had intent, worked out a full plan, and then if we're talking about the realm of behavior, they may have made an attempt or had preparatory behavior within the last 3 months. So that's our secondary screen is the Columbia screener. Okay, so then our comprehensive suicide risk evaluation. To develop the comprehensive suicide risk evaluation, so this is a tool that we developed in VA. There was a group of stakeholders from many different areas across VA who worked together on a work group where we reviewed all of the evidence of existing assessment tools. We also polled the field and asked them to send us any assessments that they were using at their local facility, and we put all of that together to come up with this comprehensive suicide risk evaluation. So we determined that there was no one assessment out there that best met the needs of our veteran population, so we came up with our own comprehensive suicide risk evaluation. All of the components of it are based on evidence in the literature. So for example, sleep is a huge contributor to suicide risk. So we make sure that's included in our risk factors. Past suicidal behavior, hospitalizations, things like that. So it's all these evidence-based factors that are built into our comprehensive suicide risk evaluation. We urge folks to really conduct the CSRE in a therapeutic and collaborative manner. So although it is a national note template, we want folks to feel really empowered to use their clinical expertise and their relationship that they have with the veteran they're serving to gather the information however they want and then to document it into the template. The goal is really to allow the veteran to share their narrative around their suicidal thoughts and any past behavior. Then once that information is gathered, they're stratifying risk. And so we ask folks to stratify their level of risk in terms of the near future, so minutes to days, and then also chronic risk, and ask that the risk mitigation strategies map onto both of those. I'll show you in a moment sort of our risk stratification tool that helps support that. These are the basic sections of the CSRE. So it goes through a bunch of questions related to suicidal ideation, then history of attempts, warning signs, risk factors, protective factors, and reasons for living. So making sure that we're getting a good assessment of what we can continue to be enhancing in terms of those protective factors and reasons for living, and then acute and chronic risk and that risk mitigation section. So on this slide, I have a screenshot of 2 different tools that are available to you all. They'll be sent out after the presentation today as handouts for you all that you can draw from, you can adapt from. This is, like I said, our tool itself is built into our electronic health record. There's branching logic built in depending on how you're answering questions. There's some things that align really closely with the VA system in terms of reporting suicidal behavior, things like that. So I can't give you our electronic health record, but I can give you this worksheet that really maps onto all of the questions and the content that are in the CSRE. So there's this principal worksheet that our folks use if, for example, they prefer to make their notes on paper and pencil, enter it into the record after the session, or they're doing care out in the community or in somebody's home. Of course, this is pre-COVID era. They can use this worksheet for that purpose, and this is available to you all. We also have a sample interview guide. So some folks have said, I wish you kind of gave us the words of how to ask these questions. So we came up with this interview guide to supplement the printable worksheet and what we have in our health record. So both of these will be sent to you all afterwards. And they're, like I said, available for use, and certainly we can consult with you, and I'll tell you how to do that. Consult with you after this call if you're thinking about implementing something like this. So just to dig into that risk stratification piece a little bit more, this risk stratification is in the clinical practice guideline, and it is available free to all of you if you would like to be using it as well. We also have some articles where we describe it sort of more in depth and presentations that are available also for free to you all. So we have all of those resources for you if you want to learn more about this or pass it on to your providers for use. So on one side of this tool, it has acute, intermediate, and low acute risk. You'll see on the left-hand side, it kind of describes the essential features. Over on the right, it's the essential action. So for example, if you're saying somebody is at high acute risk, by and large, that person is going to need to be psychiatrically hospitalized. And then on the flip side of this tool, we do the same thing for chronic risk. So you can download it from our website. We also can ship you out free laminated copies of it. So if you want to order some nice hard copies of it, I strongly recommend you do that if you're interested in this. I love having it right next to my desk. Even though I helped develop it, I still look at it and reference it. And as I'm doing my documentation, I really like having it handy there. So available to you all. Okay, so we did this thing. We implemented Risk ID. It was a massive undertaking. It involved an incredible amount of partnership across the system of care, of course. In the first year of implementation, we screened over 4 million veterans across the system, and that's actually just in ambulatory care, so that doesn't include inpatient emergency department, any of our other settings. That's just in outpatient care. We screened over 4 million patients. And then at some point, the Joint Commission told us that they had an opinion on I-9 from the PHQ-9, which, as you'll remember, was our primary screen. So that had a big impact on policy, right? We have to certainly align the Joint Commission, and so we did that. So I'm going to talk you through that because this is a very important lesson learned that I want to be sure to share with you all. So in July of 2019, is that right? Yes. The new National Patient Safety Goal from Joint Commission came out. Many of you who are hospital administrators likely know this. So there's a number of requirements in this National Patient Safety Goal. One of them is that all individuals who are served for suicidal ideation are screened using a validated screening tool. And so this is a question of what does the Joint Commission consider a validated screening tool? So we had item number 9 in the CPG as a validated tool, but does the Joint Commission agree? Well, we later found out they did not agree. So the reason that they cited for that was that the research done on the I-9, although it was very strong, it was on the I-9 when it was administered in the context of the larger PHQ-9 measure, not the I-9 by itself. Certainly now in VA, we have a good amount of data and hope to be looking at that. But at that time, when Joint Commission was collaborating with us around this, they said, you know, at this point, we are not considering that a validated tool. So for those of you who know these requirements, you'll know that they only apply to patients who are presenting with a behavioral health concern as their primary reason for presentation to care. So what we did was, you know, in our outpatient mental health clinics, we were already starting with the Columbia Screener. That was our starting point. As you'll see on this slide, the Columbia is considered a validated tool by Joint Commission, so we were fine there. That's where we're starting on our inpatient units, things like that. The big setting that was of question was the emergency department. And so in the emergency department, we were starting with I-9, but many times folks could present to the ED with a behavioral health concern that may or may not be known right from the start. We didn't want our staff to have any confusion around which tool they were supposed to use in an emergency department. We certainly wanted to make it as easy as possible. So we went and changed in the emergency department to starting with the Columbia. That is what we chose because that's what we were already using in our other systems based on our review of the evidence and what fit best for our population. But there are a number of tools, and I'm sharing the ones that are freely available in the public domain on this slide here. So these are all of the ones that Joint Commission considers validated. So again, I'm sharing with you what we're doing in VA, but there's different ways you could go in your healthcare systems for approaching this. So the ASK tool, the Columbia, the full PHQ-9, the SBQR, and the PSS-3. The link that's on this slide gives you the link to the Joint Commission sort of document that talks you through all of these. It does a nice job of describing the tools, gives information on how to access them, so on and so forth. But I did want to share the free tools with you. I know that when a system is thinking about implementing something like universal screening or even just standardizing screening, one big potential barrier is concerns about cost, right? So I thought it was important to let you know that there's many of them that are approved by Joint Commission that are freely available. So these are those. So like I said, we had this three-stage process, and then in the emergency department, we pulled back the I-9 and started with the Columbia so that there was no confusion for our providers in terms of what they should be starting with. And we would be sure that if Joint Commission was reviewing any cases seen in the emergency department, they absolutely would be meeting requirements. So that's what we did there, and wanted to share that lesson learned. Okay. So another part of the National Patient Safety Goals maps onto the evaluation portion, so our CSRE. So the National Patient Safety Goal says that any assessment that you're doing to follow up on a positive screen must include ideation, plan intent, suicidal or self-harm behaviors, risk factors, and protective factors. And as I read through that list, that might sound familiar because our CSRE does cover all of those components. And so we were good there. No changes needed to be made to the CSRE based on this piece. And then EP4, the performance element 4, said that an overall level of risk needs to be part of your assessment, and there needs to be a plan to mitigate risk. And again, that maps on perfectly to our CSRE. So in terms of the Joint Commission requirements and what we were doing for evaluation, we were good, we were covered, we cover all of those components in our standardized evaluation. But I do want to point out that in the Joint Commission documents, there's also a couple other tools that are mentioned that they consider evidence-based that can be used for follow-up assessment on a positive screen. So they specifically talk about the full version of the Columbia, so the assessment version, which is also available on that Columbia website. They also mention the scale for suicide ideation. There is a cost associated with using the SSI, so I want to make sure you all know that. But that is a great tool. We use that in VA in other ways as well, but the Columbia is available. One thing just to note that if you were to use the Columbia, it would have to be supplemented. So the Columbia does a good job of really diving into suicidal ideation and behavior. But to meet the full Joint Commission requirement, you would also have to ensure that you're asking about risk and protective factors, you're stratifying risk, and coming up with a risk mitigation plan. So you need to make sure you're covering all those elements. On the Columbia website, they do have a supplement that can be added to assess things like risk and protective factors. So you'll just want to make sure that you're using all the tools available to you to make sure you're meeting the full Joint Commission requirements if you're an organization that needs to worry about those requirements. Okay. So I'm going to dive into a few additional resources, then I will wrap up with kind of a presentation portion, and we can move into some Q&A. Okay, so I referenced consultation earlier. So many of you, or some of you may already know about this, but I want to make sure that certainly all of you know about this. We have a suicide risk management consultation program that myself and a colleague who's a psychiatrist, Dr. Hal Wurtzel, and I co-direct. This is out of our MIREC, but it is funded and supported by the VA Office of Mental Health and Suicide Prevention. This started in VA back in 2013, and then our previous secretary, Secretary Shulkin, allowed us to expand the service to community providers. And again, that expansion is really consistent with this approach that we're taking to suicide prevention in terms of a public health approach and the idea that we can't do this alone and we need to engage our community providers and organizations that are serving veterans. So if your organizations or your individual providers would like consultation related to suicide risk assessment and management, please reach out to us. You can just shoot us an email. We're a pretty friendly crew of people. We can help consult on local policy development, sort of the evidence that's in the CPG. We can talk about best practices for documentation, risk stratification, postvention, which I'll dig into in a little bit, lethal mean safety counseling, a whole host of topics. So we support providers and organizations in a number of ways. So we can do like one-on-one consultation. We set up an hour-long consultation call. It's, of course, completely anonymous in terms of the cases we're talking about. When we do this with community organizations, it's not, we're certainly not assuming care for any veteran who's seen outside the VA, but we can consult on topics relevant to the care that you're all doing. So, for example, I did a consultation with a provider in Maryland once who worked for an organization where she ended up seeing a lot of veterans, and she said, I really struggle with how to talk about firearm safety with my veterans. Can you give me some pointers? And so we talked through some of the specifics of her concerns and came up with ways that felt comfortable for her to talk about. So it's that kind of a thing. In addition to that, we have a number of trainings and resources that are available on our website. Strongly recommend you check those out. There's a way to sign up for our lecture series and newsletter on our website. So we have free CEUs that are available. We have a monthly lecture series. If you missed our lecture series that kicked off in April, when available, or as soon as they're available, we upload registration links so you can connect to those through Train and get free CEUs for those trainings that have passed, and then certainly can sign up to involve the larger groups there. So those are available to you all. You can learn more on our website, or you can always just send us an email to ask questions at SRM Consult. Obviously, right now, when I wrap up, I would answer any questions you have. But if they come later when you bring them back to your organization, feel free to just reach out with questions. We really would love to hear from you. We are highly underutilized by the community. When we do satisfaction surveys, one of our questions is, what could we have done differently? And I can't tell you how often our community providers say, you need to get the word out about your resource. The community doesn't know about you. We need to make sure that they know about you. So if you could help disseminate information, that would be awesome as well. On our website where that red arrow is kept clicking or pointing, there's a Share SRM section. We have social media posts. We have drop-in articles. If you have a newsletter for your organization, you could just plunk in there. We have images you can use. We have infographics, one-page kind of one-pagers on the consultation program, a whole host of ways that you could help get the word out. So would really appreciate your partnership in that. Okay, so I mentioned that one of the things that we do consultation on, one of the topics is suicide postvention. So postvention refers to an organized, immediate, as well as ongoing support following a suicide loss. So this could be postvention for family members in the community. This could also be postvention for providers who lose a patient to suicide. It really promotes healing after suicide loss, which in turn reduces risk for those impacted. So you'll see on this slide here in that graphic, that lovely graphic there, postvention is prevention. The more we can support those who are impacted by suicide, we are reducing their risk, in addition to, of course, just supporting them and promoting their own healing. So this is really important to consider integrating into your healthcare organizations. This is for the health and staff of the clients we serve, the veterans we serve, but also our staff, and to promote wellness among our staff. So we have a specific website related to this. It's called the Uniting for Suicide Postvention resource. It's a website. It has multimedia resources to promote open dialogue about suicide loss. There are short films to watch, infographics, podcasts. And again, it's tailored for all these different groups and sort of areas in which postvention might be applicable. So I really strongly encourage you to check that out. You can go to our SRM website and get linked to the Postvention website on there. I realized I didn't include a link on here on these slides, but we can get you there from the SRM consult page. But really recommend you check that out, and that's something that we can consult on as well. Okay, just a couple more things, and then I'll stop talking. So another resource I want to make sure you know about, and you may have heard about through different avenues and presenters and your partnerships, but just want to make sure you all know, is about SAVE. So a lot of what I've been talking about thus far is really in the clinical space. This is for our licensed mental health providers or other providers, healthcare providers that are supporting suicide prevention efforts. But some organizations are certainly interested in all of their staff, whether this is a VSO or any type of organization, in knowing what to do to help identify risk and help get somebody to somebody who can help further evaluate and keep them safe. So the way that we do this in VA is through something called SAVE, and the acronym's on the slide here. And importantly, there's a free online SAVE course. So you could, for example, disseminate this to all of your staff and recommend or require that they take this course. And it teaches them, it's sort of like a mental health first aid, gatekeeper training sort of a thing. This is for non-licensed folks who just want to be able to know what to do if a veteran is talking about suicide and what they can do to help keep them safe and get them off to folks who can help support them best. So recommend you check this out. This was done in collaboration with Psych Armor, which does a lot of really awesome training. Okay. One other resource to highlight here, I think I just have one more, is the self-directed violence classification system. So this is something else that we've consulted with healthcare organizations on. We know that it's incredibly important to have a common language around suicide. There can be challenges in sort of the research, like let's say what one system is defining as a suicide attempt, another system is not. Makes it really hard to compare data. This is really hard from a surveillance standpoint, hard for us to have really accurate data on a national surveillance level if we're not using the same definitions, and certainly in clinical care if we're speaking a different language. In the emergency department and our outpatient mental health clinic, that can be a huge problem. So the self-directed violence classification system is one language that we all can be speaking. We have a ton of training resources on our website available for this as well, and certainly something that we can consult on if your organization is interested in implementing this. And again, just to remind you all that this is completely free. This is all government work, and our support around it is all free. So finally, okay, I lied, there's at least one more. We also have a free webinar in the clinical practice guideline if you're interested in that. That is available outside of the VA as a free training as well. Of course, I had one more. Okay, there's also free training related to lethal means safety. We have a website and free training available to you. We're revamping the website right now, but it is up still, and we're just going to make it look a little bit snazzier. But this is available to you all as well, and training on how to have conversations about lethal means safety. Okay, so that was really it. There's information on the crisis line here, which I'm sure you all have, and then my contact information on Twitter, email, contact me, however. And that's all I have for presentation.
Hi, thank you, Dr. Matarazzo. This is Angela Wright with SAMHSA's SNVF TA Center. I'm so happy that you were able to spend some time with us today to go over this really critical information, and it's just so rich with resources, and just thank you so much for spending the time with us. We have a number of questions, and I want to be sure that we have some time to go through and talk about these things with the team. I want to invite everyone to type your questions in the chat. I'm monitoring that. Our team is monitoring that as well. If you're able to select all participants, it makes it easier for everyone to see. I think there may have been some issues. Just want to recognize that that's okay. Send it however you can, and our team will tackle it for you and make sure that Dr. Matarazzo is able to see those questions. I'm trying to advance the slide. Erin, could you advance the slide for me, please? Thank you. So just want to share that we have some SAMHSA resources for you as well. There's a helpline, and then there's the SAMHSA treatment locator. We invite you to use that. Also wanted to make a quick note that a lot of this material can be tough to talk about, and so if there's anything that you're feeling you need support about, please don't hesitate to reach out to us at the TA Center. We're happy to help, and also the helpline's available for you as well. So what I'd like to do is go ahead and go forward with our team discussion and just pose a couple of questions to you, Dr. Matarazzo, if you'd like to go that route. So let me just see here. I have a list that I've been compiling. And the first one is about the PHQ-9. And one of our participants asked, she says, I'm curious if PHQ-9 is a good first assessment tool to use in the community at places like a nonprofit. Do you have thoughts about that, Dr. Matarazzo?
Sure. So yeah, just to it's a good question, and just to dig in a little bit more, for those of you who are not so familiar with the PHQ-9, it's developed to be a screener for depression, and so it does evaluate all symptoms of depression, but item number 9 is the one that specifically asks about suicide risk. So I think it can be a really helpful tool to get a good sense of depression symptoms and also screen about suicide risk. So if you're interested in doing both of those things, it can be a great tool for that. You know, and again, just a reminder, the big piece of the screener is that if you're going to identify a potential depression diagnosis or potential suicide risk, you just need to have really clear plans for next steps. You don't want to identify those things and then have no follow-up. So you want to have a way where somebody can get evaluated for depression and further evaluated for suicide risk if those things do kind of pop up on those tools. So you'll just kind of want a comprehensive plan around it if you do implement it, but it's a great tool for those pieces and has a tremendous amount of evidence behind it.
Great, thank you so much. The next question that we had come in was around caregivers and families. One of our participants voiced her concern that sometimes a caregiver feels like the veteran may not answer the questions truthfully on this screener, and they felt like their veteran probably would not have. And so what can we do for caregivers and veterans who feel that their loved one's at risk, but they're concerned that they may not be answering these screening questions with the whole truth? She also mentioned, too, that she knows that the Elizabeth Dole Foundation is working with the VA on an initiative called the Campaign for Inclusive Care that's educating and implementing caregivers into the veterans care, and that would be a good way to get some more clear understanding if the veteran's at risk. Do you have any experience around that, or any thoughts about how we can help caregivers and families support their veterans when they're concerned that they may not be fully answering the screener truthfully?
Yeah, it's a great question. That's, of course, a really tricky situation, and each individual case could likely be handled differently. A couple of things I would say, kind of generally speaking, is that, you know, if that were me, I would try to have a conversation with my partner about my concern about that information not being shared. Maybe tell my partner that I was going to share that information if I chose to do that, and then, you know, reach out. As a provider, it would certainly be helpful to know that communication occurred. You know, we as providers are certainly not allowed to divulge any information to family members without a release of information. but if there is a real concern about risk, we absolutely can receive information. So that's one thing to keep in mind. VA also has a program, in case you're not aware, that's called Coaching into Care. I just put that in the chat. It's an awesome program for loved ones that are worried about a veteran, that they're, the friend, family member, or whatever. You can work with our Coaching into Care team, and they offer really helpful suggestions in terms of how to support encouraging a veteran getting into care and getting support. And they offer you as a caregiver or loved one a tremendous amount of support too. The final thing I'll say is that if you are ever, more imminently concerned about a veteran loved one, you as a family member or loved one can reach out to the Veterans Crisis Line yourself and share your concerns, and the responders can help sort you through that and help determine if immediate intervention is needed, that sort of a thing. So the crisis line is certainly available to you all as well.
Great, thanks, Dr. Mazzaro. The next question I have from our participants is related to firearm safety. So one of the participants wrote that the primary risk identification for suicide by firearms seems to be limited to purchase of firearms or ammunition. Can you speak to baseline changes such as brandishing, reckless behavior, changes in daily carry practices, pantomime with gun, etc.? And then as a follow-up, what recommendations do you have for clinicians to have a better understanding of firearms and gun culture literacy?
Great. I just found that question in the chat, so let me just reread it because there was a lot in there. I want to make sure I get all the pieces. So for the first part of the question, it sounds like, and Sarah, please let me know if I'm misinterpreting this, but it's sounding like you're asking about, the literature related to suicide risk and firearms being related to ownership, so purchasing firearms or ammunition. Well, I guess that's a question to you. If you're asking about the literature, if you're asking more about folks' behavior, so if they are doing things like having reckless behavior, brandishing, changes in daily practices, that kind of thing. If you're asking about the latter, so more so like on an individual level, if you see somebody changing their behavior around those things, that I would answer that could be a warning sign. That could indicate an elevation of risk. If we're talking about any individual person, it may or may not. But if you're concerned that it could be, then it's certainly worth checking in with that person and directly asking them if they're having suicidal thoughts. So on a sort of clinical or just human level, if we're talking about an individual who's engaging in those behaviors, certainly no harm in asking or trying to connect them, because it certainly could relate to some internal distress. Certainly not necessarily, and that's why you just kind of have to go to them to ask. If you are asking about literature, I don't know of literature that is that specific to those behaviors. Most of the literature is about firearm ownership, things like that, and associations therein. A lot of that literature is reviewed in that training that I mentioned, that's on the slides. And for your follow-up question, in terms of recommendations for clinicians to have a better understanding of firearms and gun culture literacy, awesome question. In that training, we go over some additional resources that would be helpful, but I think that our website and that training is a good place to start. The other thing that I would suggest, and this is, of course, just if folks are comfortable with this, I will speak for myself. I did not grow up with a lot of gun culture knowledge, if any, and myself was not as comfortable around firearms, but felt like I wanted to do all that I could to learn about it, especially given that I'm working with veterans. And so a group of us from our center went to a local gun shop, who did a training with us. They taught us about firearms. They let us handle, of course, unloaded firearms, learn about gun safety, so how to sort of dismantle a firearm, put it back together, that sort of a thing. I cannot tell you how much my confidence and sort of comfort talking to veterans about it, how much it went up from doing that. So that's more just like a personal clinical suggestion, but that helps me a lot. So if somebody's comfortable doing that, that could be a one way to learn about it. Only other piece I'll add is that it's important to have a dialogue with your patient, right? So just like any other diversity issue, knowing that, firearm ownership probably means something important to that person. We don't know what that is for any given veteran we're serving. So just ask them, learn about it from that person and what it means to them, because that's going to be different for every person. So.
Great, thank you so much. There's another piece to that question that was typed a little bit further down the line, and just to stay on the topic for a moment longer, what are your recommendations for off-site storage of lethal means, and what options do you have for this? What criteria do you recommend should be met before a veteran brings lethal means back into their home?
Good questions. So a lot of this will be covered more in depth in that training as well. I know I keep saying that, but I'm happy to answer it here too. But if you want something, some of that more concrete training, it'll be in that that training we have through train.org. So in terms of off-site storage, there's a lot of options. Part of giving an answer to that would require knowing your local transfer laws around firearms and then also local resources, but I can list some things to consider. So in some states, it is legal to transfer a firearm to a loved one, to a buddy, that kind of thing, if it is for safety. In other areas, that is not legal. So you're going to want to know the laws in your area about transfer of firearms, certainly before you would recommend that as a clinician or do that as a loved one. Some local police precincts will hold a firearm for somebody and then give it back when the person comes back for it. Some gun shops and firing ranges will also do that. Especially if it's a veteran and they show up and say, hey, can I store my gun here for free for a while till I kind of get through this rough patch, just as a temporary thing. A lot of times those organizations will do that as well. Certainly, the firearm community is very interested in safety and safety of our veterans, and so many of them will partner around that. So some of it's just reaching out to your local community and resources related to those entities and seeing what they're willing to do. In terms of the sort of recommendations about what criteria should be met before the veteran brings lethal means back into their home, if I was working with a patient around this and trying to help them decide what's best, first thing is that this absolutely has to be a collaborative conversation. These conversations don't work if the veteran gets even the remote sense that we're going to be telling them what to do with their firearms. That doesn't work, and that's certainly not in the best interest of anybody. This has to be a really collaborative discussion. So what I would be encouraging a veteran to think about is when do they feel like they'll be back kind of at their baseline. So let's say somebody's going through some new financial or relational stress. Once that stressor has resolved, then maybe we check back in. I worked with a veteran recently who was on our, actually on our, one of our medical units following a suicide attempt, and he did not have access to his firearms anymore. It was a gunshot wound. And part of the conversation with him was, okay, well, he was well educated about how elevated risk is post-discharge. So he made the decision that he certainly wasn't going to have his firearms for the first few months he got back home. And then depending on how his emotional stability was getting back and reacclimating with his physical injuries, he was going to talk to his mental health providers and his family when he wanted to get his firearms back, and then go on and make that decision with their input. So that's just an example of how that could go.
All right. Thank you. Thank you so much. So let's just talk a little bit about training. There's a couple of questions there, and I know that a lot of us are kind of thinking about, well, what's the best way to train staff? So one of the questions is, what is the best way to train staff and volunteers on suicide prevention? What to do if someone is suicidal? Are SOPs the best route, or pre-created trainings the best route?
I would say all of it. So, and consultation. So oftentimes what I find helpful is, there can be sort of a training that helps people sort of understand the why around a policy change that you're trying to implement. That really can help a lot with just getting buy-in to it and people getting on the same page around the intent of a policy. And then coming up with, the policy itself and then the procedures, which would be sort of in your SOP, right? So exactly what is that going to look like in a specific clinic, in a specific volunteer center, so on and so forth. And then making sure that folks are familiar with that and have reviewed it. I think role play is a really important thing to do. One thing we always say when we're training folks is you don't want the first time you're having these conversations to be with an actively suicidal veteran. You want to at least have role played it with a colleague first. It helps build our own confidence around this. This is super anxiety provoking for folks. It is scary doing this work. It is very scary. And so you want to do all that you can to build your confidence ahead of time and really feel like you know what to do in these circumstances. So role playing can be really helpful. And then as somebody is starting to practice, inevitably different questions are going to come up, right? And that's where I think the ongoing consultation piece comes in, and that's certainly something that you could have in your own organization or our team can absolutely help with as well.
Thank you. So there's been a couple of questions around the VA consultation process that you discussed in your presentation. One of the participants says, the VA consultation process is very helpful and exciting. How can people access? Is it available in all the VISNs?
Yes, it is available nationwide to literally anybody who serves veterans. So in VA, outside of VA, any person who serves veterans can utilize us. For many non-VA organizations, sometimes they'll say, well, I've actually only served like one veteran. That's okay. We will consult with you if you have served one veteran or you might serve a veteran. A lot of times veterans may present to non-VA healthcare organizations and not even identify themselves as veterans, but if as an organization, you tend to serve those who have served, even if it's a small amount of what you do, you can consult with us. It's not like we go through an extensive sort of questionnaire vetting process about how often you're serving veterans to see if you qualify or anything like that. So if you're not sure, just reach out to us because it's probably good to go.
Great. And then in follow-up to that, another person asked, can consultations be provided to hospital systems, for example, via webinar or for large groups?
Absolutely. We have a pretty large team at this point, and we have a lot of folks who can do presentations and trainings. So typically if an organization reaches out to us, we'll just get a really good sense of what you're interested in and can really tailor it to your needs. So certainly feel free to reach out if you have one of those requests.
Okay. Thank you so much. Just wanted to recognize that there's quite a bit of time left. If you have other questions, please feel free to type them up in the chat. We're monitoring that as we go along. I have a couple more left here. This is kind of within the theme of the community. What can we do within the community? And one of the participants stated, the VA is putting incredible efforts into screening and contacts surrounding hospital and emergency department visits. do we have any other best practice examples from non-VA hospitals and non-VA emergency departments for how to integrate screening into a visit and how to implement practices for follow-up suicide risk check-ins after visits? Now, Dr. Matarazzo, if you have thoughts about this, please do share, and then we at the TA Center can also help and try to follow up on this question as well.
Yeah, absolutely. It's a great question. So, yes, there's two efforts. I'm just going to put these names in the chat. I know sometimes hearing like acronyms over the phone can be hard. So there's two things that you could check out, and if you email me at the consult program, and I'll put that back in here too, I can send you some of these resources. But two different programs or non-VA entities I could highlight that come to mind. So one is Parkland. So Parkland is a healthcare organization that's out of Dallas, Texas, and they were the first to use the Columbia as in a universal screening capacity, and we modeled much of what we did off of their work. And they have a few different articles that are out describing their work, and we certainly can share those with you all. The other one I'm aware of is ED-Safe. So ED-Safe had a number of sites across the nation, I think maybe somewhere around 8, where they did different phases of their project, but they did screening, safety planning, as well as outreach phone calls. So those, there's quite a few articles related to the ED-Safe project as well. So those are the ones that come to mind at first in terms of non-VA entities.
Great, thank you so much for those great resources. Okay, so I just want to thank you so much for sharing your knowledge, and thank the participants for asking these really great questions. It looks like we have another one that just popped up in the chat. I'm trying to read it because, oh my goodness, it's so small. Let's see here. So it says, has the 988 call-in been set up, and what is the status? Are you, I know that that's something that just came out. I'm not sure. Are you in tune with the status of the 988 number? And
I'm not. Yeah, I mean, I know it's a thing and it's coming, and and that, but I don't have any sort of updates on where it's at or it's kind of the status of that.
Thank you. Yeah, I know it's fairly new, so I'm not sure how long it's going to take to implement, but we can investigate and see if we can provide some updates to our registrants. So let's see.
Yeah, it looks like some folks we might have some experts in the audience. Jonathan was saying July 2022. So.
Yes. Thank you so much, Dale, for sharing your insights. Okay. Just double checking the Q&A. Appreciate Jonathan, Joshua for sharing the July 2022 with us. That's great. Good to know. And it certainly is a huge win. Okay. Well, what I want to do next is just take a look at what we have coming up next with our technical assistance. And thank you, Dr. Matarazzo, for all of the great information. If you guys have any more questions for her, please feel free to continue to put them in the chat or the Q&A, and we'll try to get answers out to you and follow up to this session. I think we're going to go ahead and close out a little bit early, give you back a half hour of your time. I'm sure you have lots of competing priorities, so just thankful that we can have this moment with each other, and also let you know about an upcoming call that we're going to be having with Terry Tamelian with RAND Corporation. She's going to be talking about garnering policy level buy-in. Also, what's not noted on this slide too is that the state of Virginia is going to be sharing their examples of how they have briefed their governor on their work of the Governor's Challenge, and we're able to gain funding and buy-in from their leadership for some of the projects that they have taken on. So that's August 17th from 2 to 4 p.m. Eastern Time. And just look in your email boxes. That announcement should be coming out here shortly for you to be able to register for that. And so we hope that you'll be able to join us. And thank you so much for joining us today. And we'll leave you with that and wish you all well and health and safety as you go forward in your work. Thank you again, Dr. Mazzarato, and thank you to our participants.
Thank you all so much.
All right. Goodbye, everyone.